Hello, and welcome to the Duke Cardiology Conference. I'm Sunil V, Assistant Professor of Medicine here at Duke University Medical Center. Today's program is titled Percutaneous Management of Mitral Valve Disease, and our distinguished guest is Dr. Andrew Wang, Associate Professor of Medicine and Director of the Cardiovascular Disease Fellowship Program here at Duke. Andrew, thanks for joining us.
Thanks for inviting me, Sunil.
So, Andrew, last week on rounds, we were seeing a patient who is a 74-year-old woman admitted to the hospital with heart failure. During her workup, she was found to have ischemic cardiomyopathy, some two-vessel coronary disease, an ejection fraction of about 40%, and she was found to have severe mitral regurgitation. She hadn't started dilating her LV yet. We contacted the surgeons to do CABG plus mitral valve repair, and one of the topics of conversations on rounds was, what's the status of percutaneous approaches to mitral valve repair? What can you tell us about that?
Well, we'll just move on to our slides, if you don't mind, and we'll just talk about the current state of the art for percutaneous interventions for mitral valve disease. I think laying the groundwork for this is a brief discussion of percutaneous mitral commissurotomy, which is a well-accepted first-line therapy for patients with rheumatic mitral stenosis for the last 20 years. And this procedure is indicated for patients with moderate or severe mitral stenosis with a mitral valve area of less than 1.5 centimeters squared, a favorable echo score, so bringing the importance of the mitral valve anatomy for determining the right patient for percutaneous intervention, and finally symptoms or pulmonary hypertension. There have been randomized studies showing that there are comparable procedural results and long-term outcome compared to the surgical procedure of open commissurotomy. However, there is a gradual restenosis of the mitral valve after successful balloon mitral valvuloplasty at about 25% at 5 years, even after a successful procedure. So it is not curative per se, but certainly beneficial for the intermediate to long term for the patient. Importantly, also, an unsuccessful procedural result or long-term results do not preclude the eventual surgical therapy, which is mitral valve replacement, the definitive therapy for rheumatic mitral stenosis. So a lot of those clinical experiences that we've learned from the balloon mitral valvuloplasty experience will translate to management of mitral regurgitation.
So let me ask you, do you have patients that you have dilated on subsequent occasions? In fact, I guess what I'm trying to ask is, does the first initial percutaneous dilation preclude subsequent percutaneous dilations?
No, we've done repetitive procedures on patients who have restenosis if their echo score still remains favorable and they don't have significant mitral regurgitation. As we move to talking about mitral regurgitation, the complexity of the mitral valve becomes a very important understanding. A competent mitral valve depends on normal function of a number of different parts of the mitral valve, including the leaflets, the mitral valve annulus, the chordal apparatus, the papillary muscle, as well as the left ventricular wall to which the papillary muscle is attached. Muscles are attached. Because of the complexity of mitral valve function, there are surgical techniques to address problems with any of these aspects of mitral valve competency surgically. And you can see here the number of different procedures that can be performed by a cardiac surgeon based on the various aspects of the mitral valve that is dysfunctional. As we move to talking about percutaneous devices for mitral regurgitation, the devices can be grouped very quickly into two classes. One, to address malcoaptation of the leaflet, and we're going to talk in depth about the edge-to-edge mitral valve technique. And secondly, annular dilation, for which there are two classes of devices: coronary sinus devices, where there's some early human experience, and direct annular shortening. The edge-to-edge repair technique was first described by a cardiac surgeon, Alfieri, in 1995, and really was initially described as a technique for repair of prolapse of both leaflets due to myxomatous degeneration of the leaflets. It has subsequently been extended to other causes of mitral regurgitation. Very presciently, Dr. Alfieri, in one of his first papers, described that this technique, because of its simplicity, would be translatable to a percutaneous delivery method. So for a cardiac surgeon to sort of lay the groundwork, if you will, for possible percutaneous use of this was I think, quite interesting.
So what are the principles involved here when you say edge to edge? So presumably we're talking about perhaps dilation of the annulus here. Are we actually talking about degeneration of the leaflets? Is there any resection of the leaflets involved in this particular technique?
This was initially described as a very quick bailout technique in more complicated cardiac surgery where there may be regurgitation. And it was initially described for bileaflet prolapse, which is a very complex repair, but this would actually be a standalone procedure for patients with bileaflet prolapse. Now, surgically, it has been used predominantly with a mitral annular ring for annuloplasty as well, and that has been shown to affect the success of and long-term success of residual mitral regurgitation.
Is there a risk at all of and I'm sure you're going to get to this about, with some of the repair techniques, there seems to be sort of this creation of almost a double jet or subsequent iatrogenic mitral stenosis.
Right. So there is a significant reduction in the mitral orifice area. So this technique can only be applied to patients that have a relatively normal or a large mitral orifice area. If there's any degree of mitral stenosis or even a small annulus size, it is not amenable for edge-to-edge repair because there is some degree of mitral stenosis. It's generally very small.
I see.
This is a schematic of the E-valve MitraClip device, which is the percutaneous device for edge-to-edge repair. It is delivered on a catheter through a transeptal procedure. You can see in the first slide here, there are polyester-covered arms that go on the ventricular side of the mitral valve leaflets, one for the anterior leaflet, one for the posterior leaflet, and then there are grippers which lower on the atrial side to essentially capture the leaflets between the arm and the gripper. The polyester covering promotes endothelialization and ingrowth to cover this device. This is a schematic showing the delivery of the device from the left atrium down into the ventricle, grabbing the leaflets at the point of the jet origin, and then you can see it creating a double orifice of the mitral valve. This is during diastole, so that inflow to the left ventricle occurs through these orifices, but during systole, the leaflets are already opposed in the central A2P2 site of the valve, allowing better coaptation of the leaflets. And finally, this is the clip released on the mitral valve leaflet.
So a couple of things to point out here. So this is coming, I guess, through a transeptal approach. Then.
Correct.
And is that the only way? That's the way the device is designed then?
Correct.
Okay. And what other types of imaging is necessary during a procedure like this to make sure that you're actually capturing the leaflets? Or is it one of these things where you're going to capture the leaflets no matter what? Yes.
Great question. So this is performed in a cath lab setting, but the use of fluoroscopy is very limited. In fact, it is done under general anesthesia mostly or solely for the purpose of transesophageal echocardiography, which is the guiding procedure for steering this device within the left atrium across the mitral valve, centering it on the jet origin, and really making sure that the leaflets are captured with the device. And I will bring up the importance of 3D transesophageal echocardiography, which really is amazing imaging to use in the cath lab.
Yeah, I have to admit, 3D echo for me was really kind of a gimmick, I guess, but in a situation like this where you really need to understand the relationships of these things, it can be pretty invaluable. Now, because it's a transeptal approach, I guess that might preclude the use of intracardiac echo, which is often also entered via the vein. Is that a fair?
Yes, this is a fairly large device going in through the venous system. It's hard to know, and I am skeptical that an intracardiac echo probe would allow us to see the degree of the left atrium that we would need to see, especially from the right atrial side. Or importantly, as we across the mitral valve, really from the ventricular side, what the clip looks like.
Is any arterial access necessary? I mean, do you do it just to monitor pressure?
Exactly, just for monitoring pressure. If you wanted to, do left ventriculography, it would be useful, but really not necessary.
I see. Great. Please continue.
This is the design of the pivotal randomized controlled trial called EVEREST-2 trial, which recently was just reported at the American College of Cardiology meeting its one-year results. It included patients with moderate to severe or severe mitral regurgitation, and there was a high-risk registry arm for patients who had a high operative risk, specifically patients who had an STS predicted operative mortality of greater than or equal to 12%, or other significant comorbidities that a surgeon felt would place them at higher risk of morbidity or mortality. This included approximately 80 patients in the high-risk registry arm. The majority of patients were included in a randomized arm, 2-to-1 device or eValve device versus surgery at 35 sites across the country as well as in Canada. The primary effectiveness endpoint was freedom from surgery for valve dysfunction, death, and greater than moderate regurgitation at 12 months. The primary safety endpoint was freedom from major adverse event at 1 month. And these are some of the endpoints. As I said, it was powered to show a superiority of the percutaneous approach for repairing mitral regurgitation over surgery at 30 days. It was also intended to show non-inferiority of the effectiveness endpoint, which was a freedom from death, mitral valve surgery, reoperation, or more than moderate mitral regurgitation at 12 months. And finally, the secondary endpoints were symptoms as judged by New York Heart Association class or quality of life by SF-36 questionnaire and parameters of left ventricular remodeling. Here are the major eligibility criteria, just to highlight some of them. It did follow AHA-ACC guidelines for indications for intervention in patients with mitral regurgitation. We'll talk a little bit more about the importance of the core lab assessment of the severity as well as leaflet anatomy for inclusion in this study. The mitral regurgitation jet had to originate centrally between A2 and P2. A transeptal procedure had to be deemed feasible, and the patient had to be a candidate for mitral valve surgery in the randomized arm, including cardiopulmonary bypass. Key exclusion criteria for the randomized trial were patients with severe left ventricular dysfunction, renal insufficiency, or prior endocarditis or rheumatic heart disease. I want to emphasize the importance that the degree of mitral regurgitation for inclusion in this study, as well as the results with regard to residual regurgitation, were all core lab determined. And I think that's a very important point because of the variability in quantitation of mitral regurgitation severity, as we know from previous trials, surgical trials of intervention for mitral regurgitation. So all patients in EVEREST had to have moderate to severe, 3+, or severe regurgitation. All patients had an effective regurgitant orifice area of greater than 0.3 centimeters squared, and at least 2 of these other American Society of Echocardiography criteria for 3 to 4+ mitral regurgitation. And a high percentage of patients were actually denied inclusion in this study because they did not meet these criteria, but their clinical team felt that they had enough regurgitation to warrant intervention.
Interesting.
Here are the patient characteristics of the randomized trial. I'll just point out a few things. You can see that there was an appropriate balancing of the features of the patients in both arms of the study. Compared to the 2008 Society of Thoracic Surgery database for mitral valve repair or replacement, the patients in this trial were significantly older by several years, had a higher prevalence of congestive heart failure, and especially class 3 or 4 heart failure, and really was a somewhat higher risk group, if you will, based on STS score than the typical surgery patient. Here's the breakdown of the clinical trial. There were 184 patients in the percutaneous device group, 95 patients in the control group here. 178 of the patients were treated, and there was acute procedural success, meaning that the clip was implanted and there was less than 3 plus mitral regurgitation at the end of the hospitalization, and those patients were followed for the per protocol analysis out to 1 year. There were 41 patients in whom acute procedural success was not achieved, and I think this speaks to the importance of patient selection as well as the learning curve for this technique. This is the comparison of the primary safety endpoint, which is major adverse events at 30 days. And you can see here that it did achieve its intended goal of showing superiority of the percutaneous mitral clip device compared to surgical mitral valve repair predominantly. And you can see here a much lower rate of major adverse event at 30 days compared to the surgical arm, largely driven by transfusions here. Again, the safety endpoint shown here on the left-hand bar graph showing a superiority of the patients treated with the mitral clip device for any complications, specifically transfusions. And here is the effectiveness endpoint, again, a non-inferiority endpoint showing that it met its non-inferiority pre-specified margin here with a slightly reduced success rate in the device group compared to the control group with regard to degree of mitral regurgitation.
So, Andrew, this trial has obviously generated a lot of buzz when it was presented. It's also been a little bit controversial. I think I want to get your opinion on, when we're talking about major cardiac surgery, we all recognize that there's an upfront risk. So, and without being too controversial, tell me your thoughts about, using a primary safety endpoint of 30 days when we sort of all recognize that maybe surgery may end up being the loser. Was there a little bit of a straw man, do you think, in this trial, or is that a fair safety endpoint? I mean, obviously, if we can avoid surgery, that's a good thing. Right.
I think that's a great question. I think there are reasons to perhaps be critical of the design of the study, perhaps the way the study was powered to show superiority as opposed to efficacy of the device. And we'll talk a little bit more about the efficacy, particularly when we talk about functional mitral regurgitation, which is the patient that you described, where I think that what we're getting to is a little bit of a trade-off between a safer procedure, particularly for a group of patients that may have a higher upfront surgical risk, even recognizing that all of these patients in the randomized arm had to be surgical candidates. But as we move to talking about patients who may not be surgical candidates, that trade-off may be even more important, where we may be willing to accept a safer procedure with a little less efficacy, but maybe enough clinical efficacy that it's still meaningful. With regard to mitral regurgitation, you can see here that in the device group there was a significant reduction in the degree of mitral regurgitation. Here, over 90% of patients with 3 or 4 plus mitral regurgitation at the beginning of the procedure, again by core lab determination, and at the end of 12 months, 81% with 2 plus or less mitral regurgitation, 18% still with moderate to severe or severe regurgitation. And this is a per protocol analysis, importantly. In the control group, you can see also a significant reduction with a higher percentage of patients, 97%, having 2 plus or less mitral regurgitation at the end of 12 months. If we look at it broken down by 1 plus or 2 plus, you can see that it's about a 50-50 split with regard to the number of patients that had 1 plus or 2 plus mitral regurgitation at the end of 1 year, compared to the control group, where the majority of patients actually had only mild regurgitation or 0 regurgitation. So again, a superior result of surgery for residual mitral regurgitation. But as we move to talking about the clinical endpoints, a very similar reduction in heart failure severity at 1 year. The high percentage of patients shown here in the device group that achieved a reduction in Their New York Heart Association class here, 97.6% at 12 months, very comparable to the group in the surgery, 87.9% here. And by more objective quality of life questionnaire, you can see, again, an improvement here at 30 days in the device group, with interestingly, a slight reduction in the surgery group, again, because of the recovery time from surgery. But at 12 months, a very similar improvement, both in the physical component scores as well as the mental component scores of the SF-36 for both the percutaneous device as well as the control group. So, again, to reiterate, a somewhat safer procedure, less effective if you are quantitating mitral regurgitation, but the clinical benefit seems to be present. Again, this is a short to intermediate time endpoint, and whether this holds up over time, I think, will be a very important question. Mm-hmm. And finally, with regard to left ventricular volumes or remodeling, you can see, again, a significant reduction in the left ventricular end diastolic volume at 12 months, as well as the end systolic volume in the device group, and a very similar result in the surgery group here, with perhaps a somewhat greater reduction in the end diastolic volume in the surgical group. There is very limited long-term follow-up after percutaneous mitral valve edge-to-edge repair for regurgitation. The MitraClip Registry was reported in 2009 with 3-year follow-up of patients who were sort of the roll-in patients among the sites. And you can see here a gradual increase in the likelihood of need for surgery out to 3 years, an event rate of approximately 6 to 7% per year of needing surgery due to residual or recurrent regurgitation, and that percentage is higher than that's been reported after surgical mitral valve repair. Interestingly, if you compare that line to the results of surgical edge-to-edge repair without an annuloplasty, it's almost the same rate of needing redo surgery. So if you take surgery, edge-to-edge repair without an annuloplasty, it's almost the exact same rate of needing redo surgery as it is with percutaneous.
That's fascinating. What do we know about these subsequent surgeries? Do we know any details? I mean, is the clip easy to remove? Are these all these patients getting replacements? Is there any preservation of the chordal apparatus once someone's had a MitraClip? Do we know any of that?
Yeah, that's a very important question as we consider a trade-off between efficacy and safety. The results of the patients who had unsuccessful clip repair showed that all patients had their intended mitral valve surgery subsequently. So there were several patients who repair was not deemed feasible at the beginning of enrollment, and those patients who had failed clip went on to mitral valve replacement. But the majority were able to have repair techniques. They actually are developing a device to aid in removal of the clip so that it becomes less traumatic to remove this clip, especially if there's already ingrowth of the clip to the leaflets. As we move toward talking about functional mitral regurgitation due to left ventricular dysfunction, and it's very appropriate, we talked about this with regard to your patient, functional mitral regurgitation occurs about 20% of the time as causes of mitral regurgitation. After myocardial infarction, about 12% of patients have more than moderate mitral regurgitation, and in the setting of left ventricular systolic dysfunction, 30 to 50% have greater than moderate mitral regurgitation. There are two important observational studies to talk about with regard to the outcome for surgical repair of functional mitral regurgitation. This is a University of Michigan study demonstrating in a propensity adjusted analysis that there is no improvement in survival in patients who undergo surgical repair of functional mitral regurgitation compared to those that get medical therapy. And from the Cleveland Clinic experience in patients who are undergoing surgery, bypass surgery, with or without mitral valve repair for ischemic mitral regurgitation, again, no difference in survival whether the patient gets repair or not. And as a result, the AHA-ACC guidelines for valvular heart disease describe surgical repair of functional mitral regurgitation as a 2B indication, which should be pursued only after patients have had optimal medical therapy, including biventricular pacing. So a very limited accepted role for repair of functional mitral regurgitation. Having said that, I think we all know that there are patients out there with severe regurgitation that clinically may benefit from having a reduction of their regurgitation. And these are the results that were presented by Saibal Carr at the American College of Cardiology meeting in 2009 based on the high-risk registry arm of the MitraClip experience. And you can see here out at 12 months in patients who had functional mitral regurgitation, a significant reduction in the degree of mitral regurgitation, whereas before 97% had moderate or to severe or severe regurgitation, at 1 year only 74% did. And a comparable reduction in the severity of severity of heart failure here, with a significant reduction in the New York Heart Association class compared to baseline. Again, this is not randomized. This is an observational experience in the registry. In addition, there was evidence of left ventricular remodeling with reduction in the left ventricular end diastolic volume and end systolic volume at 12 months after MitraClip repair. As we move toward talking about other percutaneous devices for mitral valve repair, it's important to recognize that the surgical approach to functional mitral regurgitation entails an annuloplasty device in which a ring is placed around the mitral valve to reduce the orifice size of the mitral valve orifice. And as you can see here, there are devices that are being developed that are intended to go into the coronary sinus that mimic the mitral annular devices to reduce the orifice size of the mitral valve here. This is one of the devices developed by Edwards, the Monarch device, and this is a device developed by Cardiac Dimensions, the Carillon device. You see the very similar structure of two fixation devices in the coronary sinus, as well as a tension mechanism that shortens to reduce the anterior-posterior diameter of the mitral valve. However, there are some important anatomical considerations with regard to the coronary sinus anatomy. The majority of coronary sinuses are anatomically superior to the mitral valve annulus by a distance of about 6 millimeters. So by placing a device in the coronary sinus, it may not provide the degree of shortening one expects at the level of the mitral valve annulus. In addition, the majority of patients have a left circumflex artery that courses between the coronary sinus and the mitral valve annulus that may lead to impingement of the left circumflex if a device is placed there. Finally, the coronary sinus really mimics here in black the anatomy of the posterior leaflet, but does not extend all the way to the trigones here as an annular ring would to provide the degree of anterior-posterior shortening that one would expect or hope to get from a surgical ring. Our surgical colleagues will tell us the importance of this shortening from trigone to trigone so that the orifice area and the anterior-posterior diameter are shortened to reduce mitral regurgitation.
And I imagine that in patients who, for example, do have advanced heart failure or inappropriate candidates, they may have already had their coronary sinus access with a biventricular lead, for example. I imagine there's some technical challenges with deploying these devices in that particular situation as well. Or if a patient would subsequently need access to the coronary sinus, I would imagine might be challenging.
Yes. I've seen a few case reports describing the patency of coronary sinus to allow access for future devices. I don't know about whether the reverse is true. These are some of the early experiences of the Monarch device showing a modest reduction in mitral regurgitation from placement of these devices in the coronary sinus. And this was a group that really started with fairly moderate degree of mitral regurgitation. So here are a number of different measures of mitral regurgitation severity showing a modest about 25% reduction in severity across the board with all of these measures. And similarly, for the Carillon device here, compared to baseline, you see a modest 25% or so reduction in the severity of regurgitation by all of these measures here. In summary, I think there's work to be done, especially with regard to the coronary sinus approach for functional mitral regurgitation. In summary, I think I would leave with these points in mind. Feasibility and safety of percutaneous valve therapies for mitral valve disease are evident. The complexity of the mitral valve competency may limit success of percutaneous repair of the mitral regurgitation, and as I've said already today, there's certainly a trade-off between a less invasive morbid procedure versus the degree of residual mitral regurgitation. The relationship between the degree of residual mitral regurgitation and long-term clinical benefit is undefined, but at least at 12 months, there does appear to be significant clinical benefit for these patients. And finally, the clinical benefit is still unclear in patients like yours with functional mitral regurgitation, with the challenges of residual mitral regurgitation, the concern for progressive left ventricular remodeling, especially for patients with ischemic causes of mitral regurgitation, and finally, what's the meaningful clinical endpoint for these higher risk patients?
So that's exactly what I wanted to focus on in the last few seconds here. You know, we've talked a lot about reduction in residual MR, and that's probably an appropriate endpoint for some of these early stage studies. But I want to ask you, is that just a surrogate? Is that something that we're going to come to view like we do with blood pressure and antihypertensive therapies? In your opinion, you know, what should we be looking at? It seems like from the EVEREST data, the long-term clinical outcomes of heart failure, quality of life, seem pretty promising.
Right. My approach, I think, would differ based on the cause of regurgitation. I think that in patients with degenerative regurgitation who are surgical candidates, there obviously has to be a frank discussion with regard to the degree of residual regurgitation, and hopefully we'll have more information about the long-term results so that we can offer them a anticipated likelihood of freedom from needing a repeat intervention. In functional mitral regurgitation, especially for patients that are at higher risk of surgical morbidity and mortality, I don't know if we know what the appropriate clinical endpoint. I think in that situation, there probably is a more important shift toward the clinical benefit rather than the quantitation of mitral regurgitation. So it may come down to the difference with regard to the cause of the regurgitation and the surgical risk, depending on, sort of focusing the attention on mitral regurgitation severity versus truly clinical benefit. As you can see, a high percentage will derive some clinical benefit from this procedure.
Right, and it seems like we're still probably a few years away from getting this in everyone's hands. But, you know, with your experience, tell us a little bit about what are the technical skills that are involved, and what do operators need to be facile with? Obviously, venous access, right heart catheterization. What other things should they be facile with? I mean, this doesn't seem to me yet ready for all operators.
Yes. Technically, the device requires obviously experience doing transeptal, but that is a technique that I think is growing in its recognition of its importance for structural heart disease, and I think more and more operators are becoming experienced and more comfortable with that. I think that there needs to be a very close collaboration between the interventional cardiologist, the cardiac surgeon, and the echocardiographer. And our echocardiographer, Jamie Jollis, has a very important role, an equal role in our cath lab with regard to this procedure. So I think there needs to be a collaborative group that really is focused on these patients. As a procedure itself, however, I think that aside from the sort of early learning experience, it probably is a technique which can be extended to a larger group of operators.
So final question here. We've heard a lot about the trial data. Is there any mechanism right now for any type of compassionate use for any of these?
The eValve device is available in a continued access registry until we learn whether this device will be approved commercially. So there is an ongoing registry on a very limited basis available to the operators and the sites who participated in EVEREST 2.
Great. Well, this has been a terrific program. Thank you, Andrew, for giving us a glimpse into the near future. My guest faculty today has been Andrew Wang, one of my colleagues here at Duke. Andrew, thanks again for such a great presentation. Until next time, then, from all of us here at Duke, this is Sunil V saying thanks for joining us, and take care.